Thank you, Hania, for a lovely intro. So I'm Tuqa Afifi. I'm a fourth-year medical student at Qatar Medicine in Qatar. So I'm going to be moderating the event tonight. We will start our conference with our first speaker, Dr. Salman al-Jerdi. Dr. Jerdi is an assistant professor of neurology at Qatar Medicine in Qatar and the director of the neurology clerkship. He's also a vascular neurologist at the Hamad Medical Corporation in Qatar. Dr. Jerdi graduated from Qatar Medicine in Qatar and moved to the United States to pursue his clinical training. He completed his internship in internal medicine at New York Medical College's Westchester Medical Center in 2013 and his residency in neurology at the University of Vermont Medical Center in 2016. Afterwards, he completed a vascular neurology fellowship at the University of Iowa Hospitals and Clinics. Throughout his time in the States, Dr. Jerdi was heavily involved in medical student and resident education. During his residency, he was officially appointed as instructor of neurology at the University of Vermont's Larner College of Medicine. He also co-developed the first formal neurology board review course and first introduction to clinical neurology course aimed at resident education. In 2015, he was the recipient of the Arnold Gold Foundation Humanism and Excellence in Teaching Award. Dr. Jerdi was a sub-investigator on multiple clinical trials focused in particular on the cerebrovascular disease. Currently, his research interest involves aspects of management and acute ischemic stroke, stroke recovery, and innovation in medical education. His professional interests involve disparities in healthcare and healthcare management. With that, I'd like to welcome Dr. Jerdi to give his talk on telemedicine in the field of neurology.
Well, thank you very much for that very kind introduction. Very much appreciate that. Everybody, welcome. I'm very happy to be with all of you today, and I look forward to spending 30 minutes talking to you about something that's been of an increased interest to us in neurology, and as a stroke neurologist in particular, this is something that's been developing over the past decade or so. I just want to thank everybody for the organization and just being absolutely fantastic, and I look forward to spending some time and answering your questions. So I'm going to talk to you about the role of telemedicine in neurology, and here's kind of an overview of the contents. There's going to be an introduction about whether there's a need for telemedicine in neurology. We're going to talk about what teleneurology is exactly, and we're going to focus on some applications of this technology, essentially. And then we're going to zoom in on Qatar, which is where I live and practice, and we're going to talk about some future directions. So very vast topic, and we're going to try to do some justice for it in about 30 minutes or so. So is there a need for telemedicine in neurology? This is a report that goes back to 2004 from the WHO and the World Federation of Neurology. And I'm going to quote, "Available resources for neurological services in most countries of the world are insufficient compared with global need for neurological care." But this was 2004, right? If we zoom in and we come in a little bit further ahead, this is 2015. This is from the UK's NHS, National Health Service, something that the country very much prides itself on. So, and again, I quote, "Neurological care is fragmented and poorly coordinated across health and social care providers. Patients admitted with a neurological condition rarely see a neurologist." This was absolutely sobering. "Services are not sustainable in their current form, and redesign is needed." So this clearly indicates that there is a problem. Something more related to our region, so the Middle East and Africa together. This is a kind of a statistic about how many neurologists exist per capita. So in the Arab world, there's actually one neurologist for every 300,000 patients, every 300,000 people. And in Africa, this number is actually 1 in 5 million, with some nations in Africa having one or no neurologists at all to take care of neurologic diseases. So this is clearly a staggering problem, and there's a staggering need for a solution for this problem. So if you guys know me, you know I like maps, and this is kind of a map of somewhere in the United States where I trained. So this is Iowa City, Iowa, with the arrow, and you can see the University of Iowa is located in the city, and this is the University of Nebraska Medical Center located in Omaha, Nebraska. And between the two of them, there is a distance of 400 kilometers or 250 miles. And there is not a single center that provides comprehensive neurologic care, even in Des Moines, Iowa, which is the capital of the state. And so a person that lives anywhere in this area would have to travel a significant portion of time in order to arrive to receive care. And these universities are considered leaders in some sense for different aspects of neurology. Here's kind of a zoomed out picture. So this is a part of the Midwest. The labels on this map exist at this point, and I'm going to highlight where you can find a comprehensive neurological center, and so something with a university attached to it and a department. And you can see they seem to be relatively scattered around, okay? But there are large areas of the country where people have very poor access to comprehensive neurologic care and often have to travel for 2 or 3 hours in any direction to receive care. So clearly, even in the United States, this continues to be a major problem. So what is teleneurology exactly? So we know that we need it, but what is it exactly? So if we want to simplify it, it's basically a branch of telemedicine which allows experts in neurology to deliver care to their patients using video conferences. And they can use that either in replacement of or in supplementation of in-person care. So it doesn't have to be one or the other, it could necessarily be both. And the biggest kind of a loop here is whether the care is synchronous or asynchronous. And teleneurology, like many fields of telemedicine, can provide both. So what do I mean by that? So synchronous care can be divided either into direct or indirect care. I think the most famous example of direct synchronous teleneurology is telestroke, and we're going to talk about that in some detail today. Providing acute consultations in hospitals to physicians and to patients that are coming in with relatively acute presentations of neurologic disease, or providing outpatient evaluations. We're going to talk about this because this doesn't necessarily have to happen in a healthcare setting, but it can happen at home using smartphones and things like that. And indirect but synchronous care, which is something like intraoperative monitoring. If you guys can see here, this is a picture of a neurologist looking at an EEG recording during a carotid endarterectomy procedure. And this can be done either directly in the OR, or what's becoming a little bit more common is people who are not even in the hospital. These are companies or things that cater to multiple health systems where they have somebody centralized reading different EEGs intraoperatively, directly or synchronously with the procedure, but they're not physically located in the same room as the surgeon. There are examples of asynchronous care. So for example, reading and interpreting neurophysiological testing. This happens with EEG and some other tests, looking at neuroimaging, or just asking for a second opinion or discussing cases that are very complicated. And I'm using examples like discussing tumor boards or doing undiagnosed case consultations. So there's really a vast amount of different aspects to teleneurology. What are some of the benefits of teleneurology? So there's many, and you can really look at them different ways. These are some that I found to be more common. And I think the most obvious one is something like improved access to specialists and super specialists. And what I mean by super specialists is a neurologist as a specialist, and then a neurologist who specializes in a subfield of neurology or a subspecialist, and then those who subspecialize in a field of the subspecialty. So movement disorders would be a subspecialty of neurology, and then somebody that subspecializes in Parkinson's disease, for example, would be a super specialist. And as you can imagine, these are very rare, and they don't even exist in every academic department, but teleneurology allows us access to those patients, to those physicians. Increased efficiency of healthcare delivery, so people don't have to drive in order to get to the doctor. And if you've ever been to a hospital, you realize that there's a lot of waiting going on, and a lot of this can be shortcutted when you're delivering healthcare via telemedicine. It allows patients with impaired mobility to stay at home. And if you guys are familiar with neurologic disease, one of the most common challenges that we have with patients is it's very difficult for them to get in the car and to come to us. And so this would help significantly by bypassing some of the logistics of mobility for these patients. So improved patient retention and follow-up. Again, we can see them once in the clinic, and then we don't have to lose follow-up because of all of these other reasons. We can see them in their own primary care doctor's office, in other centers, or even home. And there's an average decreased length of stay. And this is true when somebody is admitted to a hospital and they receive expert neurologic consultation through teleneurology, as opposed to not having that service be available. So I think let's just jump right in and talk about some of these applications of teleneurology. And this is, I think you're going to see me get excited about this. This is telestroke. This is something that we're very excited about in our field. and is something that has been around for quite some time now. So the concept was established in 1999 by Dr. Levine and Dr. Gorman. I have their pictures up because I had the privilege of training under Dr. Gorman at the University of Vermont. He now practices in Maine, and I think Dr. Levine practices in Brooklyn. So they came up with the concept of telestroke, and since then it has become something that's very important. But let's talk about stroke for just a minute. So in the US, every 40 seconds, somebody has a stroke, which means about 800,000 people have a stroke every single year, and almost a quarter of them have already had a previous stroke. And a third of the patients that have a stroke that are admitted into the hospital were younger than the age of 65, and this was back in 2009. And the data is actually showing that more younger people are having stroke now compared to 10 years ago. In terms of mortality, so this is a very serious illness. It's actually the 5th most common cause of death in the United States and the 2nd around the world. Every 4 minutes in the US, somebody dies from a stroke, which is almost about 140 or 150 deaths, or 5%. So 1 out of every 20 or 1 out of every 19 deaths in the US occurs because of a stroke. In the world, if we look at this globally, there's about 15 million new strokes every year, or about every 2 seconds, somebody has a stroke. And it's among the top 3 causes of mortality around the world, depending on where you look, and premature mortality. So these patients could have lived a lot longer had this not happened. So around the world, 6.7 million people died of stroke in 2015. This is a very large number of patients that are suffering from this disease. So the acute treatments, what we have to treat stroke, is essentially divided into intravenous thrombolytics, things that we give patients intravenously, like alteplase, or newly introduced to the field tenecteplase, or mechanical thrombectomy. And the issue with these is, like STEMI and like a lot of issues with cardiology, for example, they're time sensitive. So intravenous thrombolytics have a window of 3 to 4.5 hours for now. You're gonna see this change probably in the next few years. Mechanical thrombectomy, depending on your physiology and depending on neuroimaging, has a window of opportunity, essentially, of treatment between 6 to 24 hours. And you can see here a picture of a right middle cerebral artery or right MCA occlusion being opened after mechanical thrombectomy and reestablishing flow. So with this, the concept of time is brain formed. And I think these are concepts that will allow us to stress the importance of how critical it is to get to medical care as fast as possible when somebody has a stroke. So with every 15 minutes of delay to IV thrombolytics, there's increased mortality in the hospital. There's an increased risk of symptomatic intracerebral hemorrhage. There is a lower rate of achieving independent ambulation and the lower rate of discharge home. So you're much less likely to go home every 15 minutes of delay. For every minute, literally every minute, we lose about 2 million neurons, 14 billion synapses, and about 12 kilometers of myelinated fibers. So this is really extensive damage that happens and really documented by Jeff Saver out of UCLA. So here's a paper that looked at, essentially a meta-analysis that looked at what happens when somebody is delayed to receive IV thrombolytics. And I think it's very clear if you look at modified Rankin scale in terms of outcome, the probability of achieving 0 or 1, which is minimal to no disability at all, decreases and it becomes almost 0 at 270 minutes, between 270 and 300 minutes. Mortality goes up, intraparenchymal hemorrhage and hemorrhagic transformation goes up. And these graphs, I think, demonstrate a very clear difference between 0 to 90 compared to like an hour and a half to 3 hours. And then as you go forward, you can see the difference in outcome for these patients. The same is true for mechanical thrombectomy. And it actually becomes very interesting even if they achieve what we call a modified TICI score of 2B to 3. This is congruent to a TIMI score with STEMIs. And if you can see, this actually, the benefit decreases and decreases until it stops becoming statistically significantly different at about 6 hours. So the longer they wait, the less likely they are to achieve good recanalization. And incidentally, this is true also for outcomes. So a modified Rankin scale here of 0 to 2, so even slightly more disabled, but still with moderate to mild disability, There is no statistical difference after 6 hours in this meta-analysis when you look at mechanical thrombectomy. So the earlier, the better. Time is brain. I think this is very clear in this instance. So here's where telestroke comes in. This is called the hub and spoke model, where there's essentially a comprehensive stroke center, which is a stroke center that's able to provide IV thrombolytics, mechanical thrombectomy, 24-hour neurosurgical care, and 24-hour neurointensive care. And this is essentially ideally what you want everywhere. But as we all know, and as the slides before showed, this doesn't exist everywhere. A lot of the time, patients go to rural hospitals or the spoke. And the idea of having a physician who's at home or at the office and able to examine patients helps determine how the cycle becomes more efficient, and uses many different models to do that, but essentially allows a patient that goes to a rural hospital to receive immediate medical attention through telestroke versus if somebody would be delayed all the way until they arrive to a comprehensive stroke center. So there's actually different models that have been developed in utilizing telestroke. And the one that we're most familiar with is giving people care and then transferring them to a comprehensive stroke center. But actually, you can use the flip side of the equation and keep them at primary stroke centers if their care does not require a person to be transferred to a comprehensive stroke center, but rather they can stay close to their family and close to home and receive all the adequate care that they need with the support of a comprehensive stroke center through a teleneurology or telestroke service. The introduction of the mobile stroke units has become something that is record-breaking in terms of times of treatment, and we're going to talk about that in some detail. And telestroke has also been used to provide stroke rehabilitation consultations where people have no access to specialized neuro rehab or stroke rehabilitation programs. Let's explore mobile stroke units, which are commonly known as the stroke ambulance. So in the image here, you can actually see the inside of a stroke ambulance. This is work by a group in Germany, Dr. Fassbender. And if you see, there's actually a CT scanner, which is in the ambulance itself. And so the ambulance gets dispatched after somebody calls 911 and says, I think I'm having a stroke. The ambulance gets dispatched. The EMTs on the ambulance are actually able to perform a comprehensive neurological assessment for the patient and look for signs of stroke. They speak to a neurologist. You can see the camera at the top of the ambulance, and the neurologist is able to, with video, evaluate the patient and examine them, and is able to view their CT scan and determine whether they are candidates for IV thrombolytics. And so classically, if we look at the conventional model, an ambulance just stabilizes the patient, brings them to a primary stroke center, which is probably nearby. They get a diagnosis, they get thrombolytics, and then they get triaged, whether they stay in the primary stroke center or they get transferred to a comprehensive stroke center. With the mobile stroke unit based care, they actually receive a diagnosis in the ambulance right next to their location. They start their TPA treatment right next to their location. And you can imagine the impact that that would have based on the parameters of time that we talked about. And then they're actually triaged to whether they should be immediately taken to a comprehensive stroke center and completely bypassing the step of primary stroke center, or if they do not require that level of care, then they can just go to a primary stroke center. And as you can imagine, this is going to become really standard of care once it's available more widely around the world. This is from 2017. You can see a map of the area where there are active, which is the red triangle, active programs, or blue circles, where there is program that is being developed or being researched. You can see we're one of the few in the area that have a program that is under development for a mobile stroke unit. So this is from 2017. I must confess there are more programs now, but I just couldn't find a nicer map to demonstrate them. So this is for telestroke. This is our pride and joy, and I'm biased, and we talk about it, we really enjoy it. But what about some of the other neurologic conditions? What if the situation is not immediately acute, or something doesn't require urgent neurologic care? So it turns out there's just as important of a need. This is a statistic from 2011. So 40% of patients in the United States who are above the age of 65 who are diagnosed with Parkinson's disease do not see a neurologist in 4 years, or haven't seen a neurologist in 4 years. Now think about this. Almost half of these patients have not seen a neurologist, not even a super specialist, but a neurologist in 4 years. And not seeing a neurologist, when people looked at this retrospectively, was associated with an increased risk of hip fracture, placement into a SNF, and actually a risk of death compared to patients that did see a neurologist in the 4-year period. So again, I think this demonstrates how important it is to have this issue here. So this has sparked an interest in teleneurology, and this is a group that did a review from 2018 that looked at the publications of teleneurology and telestroke in PubMed. And I think it's pretty clear from the chart that there is a clear exponential increase in the number of publications. So teleneurology studies meaningfully began about 2000, where you can see them here, but it's really not until 2008 or so that they became more robust, and the field has increased significantly since. Orange is all other specialty care, and gray is for stroke. Same goes for utilizing things like wearables or smartphones. And you can see, again, with smartphones, the data is becoming more and more solid. But really, 2015 was the first year where things were becoming more robust. Before it, the number of studies was not very significant. So very exciting, large increase in amount of studies and a lot of development up ahead. Some of the conditions, and this is by no means an exhaustive list, but some of the conditions that can be managed with teleneurology include things like movement disorders. And again, these patients are really prime candidates for receiving subacute to chronic care without having to spend a lot of time coming to us. People with dementia, people with headache or migraine, low back pain, multiple sclerosis, myasthenia gravis, or muscular dystrophies. Really just a big variety, a vast array of conditions that would benefit from a teleneurology service that is not necessarily catered at acute care, but rather at chronic care. This is a study from 2017 from a group at the University of Rochester. These guys are excellent at providing care for Parkinson's disease, and they were really pioneers in developing the teleneurology aspect of it. So the study randomized 195 patients to either usual care, which was an in-person visit, one, or usual care and 4 supplementary virtual home visits. So this was utilizing smartphones or tablets and actually seeing a neurologist who's a Parkinson's disease expert in person on a screen. And the study compared feasibility of this and efficacy, and they used those as primary outcomes. So essentially, 388 virtual visits were completed, which was 91% of the maximum amount given the formula of 4 multiplied by the patients. And 98% of the patients that were in the intervention arm, so the ones that received the supplementary visits, actually completed at least 1 virtual study. So this was very feasible, and there was no difference in efficacy compared to in-person care. So if they received in-person care versus if they had supplementary visits, there was non-inferior results, or there was no significant difference in the quality of care and efficacy of care. However, the patients that did get the supplementary visits were calculated to save 88 minutes and 38 miles compared to the people that did not. So this is becoming very interesting when we talk about convenience, right? So this is, I just kind of grabbed this from the paper. And if you look, the vast majority of patients strongly agree that it was more convenient, that it was more comfortable, and they actually preferred visits overall is kind of about 50%, and then the neutral takes you almost to 80%. Better personal connection was very interesting because a lot of people had a better connection 50% of the time and were neutral up to 75%. And some people even thought that they got better care when they had the supplementary visits. So although still clearly in its infancy, we can see that there's a lot of potential and a lot of growth. This is another study from 2017, a big year for teleneurology apparently, that looked at headache. And so this randomized a much larger amount of patients, 402, either to an in-person visit, and they could have multiple, and virtual visits, and they could also have multiple. And their primary endpoint was actually efficacy measured at 3 months and at 12 months. And they had a safety endpoint, which is discovering a secondary cause of the headache, meaning that the person's headache was because of an underlying tumor or brain bleed or vascular malformation or something that was not initially known. So if you look at the diagrams, I think it clearly shows you that there is no difference in the efficacy of care. And if you use statistics, they calculated that they would require 20,200 visits using teleneurology to miss one cause of secondary headache that would have been detected in person. So a number needed to harm potentially of 20,200, which is basically negligible when providing care that could potentially be improved upon as the care and as practice with this technology becomes more commonplace. So very quickly, just to kind of zoom in on Qatar and talk about what we did. This is a brief chart. So before COVID, we were doing telestroke. We were doing teleneuroRadiology, where we were evaluating patients' scans using our colleagues from radiology's expertise that were obtained in all centers of care around the country. And we were centralizing them and reviewing them at Hamad General Hospital, which is the mothership of providing care in the Qatar healthcare system. And we were doing a lot of second opinion and asynchronous teleneurology with cases that were essentially being seen as outpatient cases in other hospitals where the neurologist did not have the necessary subspecialty to treat this patient. These patients would eventually be transferred back to us, referred to us for care. We would see them once, and then for convenience of travel, we would evaluate them and follow them through their primary neurologist using teleneurology. Post-COVID, things changed around the world, things changed here, and so we added neurophysiologic testing interpretation. So people that were in COVID specialty hospitals or hospitals that were mainly catered at taking care of COVID patients, as you guys are aware, there's a lot of neurologic complications related to COVID. And so we were able to obtain neurophysiologic testing such as EEG or neurologic evoked potentials, somatosensory or motor, and using these to determine care for the patient, even without physically being next to the patient sometimes. And the other thing is we largely discontinued patient visits, as a lot of the world has, and we've switched to telephonic outpatient visits with a plan of including video in the coming future to increase the efficacy of evaluating patients. So at this point, in addition to the above, we've added telephonic visits and we have added neurophysiologic interpretation remotely. So to quickly talk about future directions, there's going to be a lot of this in the future. I don't think it's any secret that COVID just put the pedal to the metal with this stuff and we're going as fast as possible. But this was looking pretty promising even before COVID. So there's going to be an increase in the utilization of small healthcare facilities. And there's going to be even an increase in utilization of smartphones. I think we were discussing some of this with some of our colleagues before the meeting. And everybody is going to be moving in that direction because this is going to provide a lot of good care to patients, we think, and is going to supplement, if not entirely replace, in-person visits. People are going to start expecting on-demand teleneurology and on-demand telemedicine, so we can bank anytime we want. We can watch, things on video streams anytime that we want. People are going to start expecting that they're able to see their doctor or they're going to receive healthcare advice anytime they want. And I think this is something that we're going to cater towards in the future. And the trick is going to be able to find out how to safely do this. The other thing that telemedicine and teleneurology facilitates that an in-person visit makes very hard is models such as one-to-many and peer-to-peer. So one-to-many is when one practitioner leads like a group of patients, and it could be a support group as exists now, but it could be many patients with multiple diseases or the same disorder that are speaking to a physician about a common problem that they're experiencing, and the physician uses them to support each other and to bring up ideas about what works and what doesn't, in the meantime providing medical advice and appropriate care for these patients. The other, which is known as peer-to-peer or many-to-one model, so is kind of the opposite, where a patient will go and see a doctor, and then typically a doctor says, well, you would benefit from receiving care from a physical therapist, and then they end up referring them and waiting till they get an appointment. In this model, what would happen is they would receive care from a doctor, be connected to a physical therapist, be connected to a social worker, be connected. So the patient actually ends up seeing a multidisciplinary team rather than seeing one person in a visit. And we think that this really accelerates the care and the benefit to the patient. And then lastly, you know, it's not all roses. There are some challenges to this. There's the obvious technological challenges like internet access or smartphone ownership. So although in high income countries, this is not as big of a problem, the world is made up of middle and low income countries a lot more. And these people are going to have a lot of challenges relating to this. Policy obstacles, right? So things like reimbursement or credentialing. And I've highlighted this because COVID has dramatically changed this, but you know, we're not at a steady state yet, and things are going to keep developing so that we can overcome some of these challenges. When it comes to disruption to local care, there's something that we call disintermediation. So people who are locally available and are working very hard to provide care to the patients sometimes feel disenfranchised or kind of marginalized, and their role is being taken out of the care of the patient. And this doesn't have to be true, but rather we can utilize teleneurology and telemedicine to incorporate them as assets in providing the best care possible for the patient. And then lastly, and I think most importantly, is the social implications of it. So most of the studies that are being done about telemedicine in general and teleneurology in specific are catered towards educated, white, high-income people. These guys are already familiar with the technology of being able to use a smartphone, and they already are better served in terms of healthcare than some people that may be in very rural areas or uneducated or have lower income. And so we want to make sure that when teleneurology and telemedicine seeks to decrease these issues with healthcare and the disparities that we face, that they don't actually end up increasing them. And so we have to figure a way to cater our studies and to cater our care towards people who are less potentially familiar with the technology or are less able to afford it. So in summary, current neurologic care worldwide is insufficient, and there's a significant need for teleneurology. Teleneurology is safe and effective, as it looks from the data, and telestroke, again, is leading the way in providing this care. There is a dramatic increase in the utilization of telemedicine in neurology, and we anticipate that to essentially be exponential over the next decade. And although some challenges remain that we have to focus on, we're very optimistic that this is going to become something that is commonplace and something that everybody utilizes to provide better care to our patients. And with that, I'd like to wrap up and thank you very much, and I'll take your questions now.
Thank you, Dr. Jerdi. This was a great talk, and it's wonderful to see like the potential of telemedicine and multidisciplinary care later on in the future. So we actually have a few questions. The first one here is, we saw a rise in telemedicine with the ongoing pandemic, but do you think diagnosis made on a video conference call can be trusted?
I think that's actually a really good question, and it's something that a lot of people have been struggling with. The data is very reassuring. There's been many studies that have looked at the difference between NIH stroke scales that were done in person versus using a camera, and some other neurologic conditions. So the neurologic examination is very extensive and complicated, as you can imagine, and treating and examining something like reflexes is going to be very hard to do on camera. But when we look at the overall picture, there is not a concerning difference in diagnosis between somebody doing the exam in person and somebody doing the exam on camera. And part of that is because when somebody's seeing you on camera, if you're in the hospital, there is a trained healthcare practitioner. There's a doctor or an NP or a PA who's actually examining the patient at the same time, and they can talk about if something contradicts what they find or something like that. So overall, great question, but we're not very concerned at this point.
And that actually may address a couple of more questions that asked about the physical exam. So one was, for example, saying that while teleneurology has tremendous application, how does it circumvent the issue of not being able to administer a physical exam?
I think what you guys have to think about is there are, just like we train medical students and residents, and we keep on training on providing the best possible exam in person, we're just going to have to train on doing the best possible exam using telemedicine. And it's very doable. It's clear that people have been able to do it without a lot of error. And so the more we practice, there seems to be more of a fear than a problem. And so I think the more we practice and the more we just get out there, and you kind of learn to swim by swimming, and so you learn how to examine patients by examining them. So the more people try it, the more they seem comfortable and have less of a concern with the physical exam.
And there was another question about the Parkinson's study. So in the teleneurology Parkinson's study, do the 4 virtual visits happen in replacement of supplementation to the traditional visits?
So that's a good question. That was one of the criticisms of the study. They were actually supplemented, not instead of the usual care. And the usual care was defined as 1 in-person visitation. And that in-person visitation did not specify the specialist that was seeing the patient for that 1-person visitation. So in the Parkinson's study that I cited, it was in addition to rather than a replacement of, but there has been more data about Parkinson using virtual visits in replacement of, but most of the studies have an initial in-person visit where the diagnosis is made and confirmed, and then follow-up is essentially done using teleneurology visits. And that seems to be the best direction going forward, with not 100% replacement, but a single in-person at least, and then followed by periodic teleneurology. And then if the need is decided that I need to see this person in person, then you just ask them to come over and you see them.
And next, there were a couple of questions asking about if the one-to-many approach would violate any privacy issues or any HIPAA rules.
So naturally, this would happen with patient's consent, and it's not like the patient would open the camera and realize there's 30 people around them. But if you think about it, patients go to support groups anyway, and people go to support groups anyway. So this is not really a radical idea. The difference is introducing convenience. You can potentially introduce anonymity that doesn't exist by not showing your face or using an alias, but we obviously don't encourage people to do that unless there are circumstances that are appropriate. And most of all, a lot of support groups are led by non-clinicians, and that's not necessarily a bad thing. But sometimes it helps if there is clinical expertise in the group, and that provides towards directing the conversation into a better direction, or discussing the news of a new drug being available on the market and now being available in the state to be offered to these patients. So I think there are definitely challenges to that, but there's a lot of potential that we can maximize on with the one-to-many approach.
And next, we have a question asking, do you have claims from some of your patients?
Claims about their experience?
Yeah, it doesn't exactly specify.
Okay. So, well, you can correct us, and I think we're just basically feedback from the patients. So, personally, from telestroke, patients don't experience stroke, both telestroke and real stroke, hopefully, so they'll have only one experience. So it's going to be a little bit difficult to compare, but generally people, we think, receive appropriate care. Our local experience has mostly been using telephonic phone calls to telephonic evaluations with patients. And although I can tell you from our end, it seems to be pretty limited in terms of being able to physically evaluate the patient. There's definite value in being able to see them and them being able to see us. For patients that are follow-up patients, that are long-term patients, they seem to be very satisfied with this. We don't have published data about it yet, but just anecdotal experience, they seem to be pretty satisfied about it. Now, I would imagine they would be more satisfied once this develops into a video stream and we're able to share images, lab results, and things like this with them. But for now, they seem to be pretty satisfied. Newer patients find it to be a little bit more challenging to form a connection when they can't see us. So if it's a person that's being referred to us for the first time, it is tricky to talk about their personal experience, perhaps topics that are a little bit more sensitive. But in general, with follow-up, seems to be going pretty good.
Okay. And we have a question about the neuro exam specifically. So how do you assess rigidity on a video exam?
That's really tricky. So I am no Parkinson expert, and I think there's probably people that are better qualified than me. But if you recall, rigidity is a non-velocity dependent resistance to movement, and so we are actually able to ask the person about it, and then have them perform pre-specified activities like carrying something and moving it around, repetitive movements and writing, and using those things and comparing side to side or comparing previous visits with the in-person visit and with the person's baseline if we know it. And we're kind of able to determine how rigid a person is to a certain extent.
Okay, interesting. And someone asked also, what if, do you think that you may not notice or miss some important symptoms because of the limited camera view?
So by definition, symptoms are what a patient complains about, and we hope that a patient is able to share comfortably what they're feeling. Do we miss any signs, I think is probably what they meant by the question. And the answer is, it's hard to say. I mean, so for headache, for example, the data didn't show that anything was missed. In fact, if you go back and read the text of that headache study, there was one patient in the control group that had a secondary cause of the headache and one patient in the intervention group. They were actually equal. And so it didn't seem like it was such a big deal. Now, when you're talking about something like papilledema, which is a finding that requires a lot of skill to view, we're not going to be able to see that when we look on the camera. But this is where we utilize something like a local doctor, an ophthalmologist that can evaluate the patient and communicate results with the patient and with us. And so this is where the practice doesn't have to be completely in replacement of the local doctors, but rather in supplement or in complement. So we help them and they help us rather than us taking over the business.
One of our attendees clarified her previous question about the claim, and she meant claim as in misconduct or malpractice.
Misconduct or malpractice, thank you. So as far as I'm aware, there is not been a concerning trend with malpractice, but I can't recall off the top of my head a paper that specifically addressed that. Happy to look that up and share some information in the future. But as far as I'm aware, there doesn't seem to be a concerning trend. In fact, in many ways, there's a reassuring trend, and this is why a lot of people are embracing the practice.
All right, thank you. And the last question would be about interference with something like a stroke, since it's an emergency and intervention is timed. How can telemedicine be a replacement of regular practice in this case?
This is a great question. So my favorite topic, right? Thank you for asking. Thank you for making it the last question. Look, I mean, the truth is interventional care specifically and stroke care generally is even less common and less available than neurology care. And I think I demonstrated how rare neurologic care is anyway and how insufficient it is. So stroke care is quote unquote even less. And it's been a very real challenge that say somebody in the middle of Manhattan or in the middle of Doha has a stroke, they have much better access to a hospital than somebody that has this in like rural Wyoming or somewhere in the middle of the desert somewhere. So it's really tricky, and we don't think there should be a difference in importance of these patients. So we're trying to utilize the ability to extend our services rather than to compete with our service. It's typically the same providers that provide stroke care in person that provide telestroke care. And this is important because the patient gets a continuity of care that wouldn't have otherwise happened. Now, this is not the model everywhere. Some hospitals utilize private companies or different companies to manage their telestroke, and then they send to a comprehensive stroke center if they need it. But the models are kind of, being decided at this point, and people are toying with this and that. Compensation plays a role. But in general, we're using this to expand available care rather than to compete with available care. So if they show up to our hospital, we're not going to talk to them via, Zoom or anything. We're going to go see them. But if they're not there and we're not physically next to them, then we're going to try to reach them as fast as possible in any way possible, whether this is through the hub and spoke model or through the mobile stroke unit model.
All right, thank you, Dr. Jerdi, so much for answering the questions. I'm glad to see this much engagement